This meeting is being recorded.
So, hello everyone. I am Dr. Anusheel, and the topic of my presentation is Alzheimer's disease in relation to patients and caregivers. So, before I start this presentation, let me take you over how are we going to go about this presentation. So, we are going to discuss Alzheimer's disease, the basic statistics involved around Alzheimer's, the basic pathophysiology, and newer diagnostic methods. And then we'll shift our focus to basically patients and caregivers and the coping mechanisms that are very vital for better prognosis of the Alzheimer's patients. So let's go ahead with the presentation. So this is an image that I had clicked around 3 years back. And while researching for this topic, I was thinking how to talk about this particular image with respect to life. So as you see in this image, a little twig starts. That's how life is born. And it's in full bloom in the middle. And then it slowly withers out. But while researching, I came across this quotation by Greg O'Brien, which complements the image. And this is what it says about Alzheimer's. That Alzheimer's is not about the past, the successes, the accolades, the accomplishments. They offer only context and are worthless on places like Pluto. Alzheimer's is about the present and the struggle, the scrappy brawl, the fight to live with the disease. And that clearly signifies what Alzheimer's is all about. So let's go ahead. Basically, Alzheimer's is a form of dementia. So what is dementia? Dementia is an umbrella term which has been replaced by DSM-5 in the newer DSM-5 by a term known as major neurocognitive disorder, MND. So dementia per se is an umbrella term under which there are multiple causes of dementia, out of which Alzheimer's is the most common cause, comprising 50 to 75%. Now, there can be irreversible forms of dementia as well as reversible forms of dementia. Mostly, it is irreversible. What are the reversible forms of dementia? So these are hypothyroidism, normal pressure hydrocephalus, and pseudodementia as in depression, and drug interactions. Drug interactions play a vital role. That's why we actually have to take proper history from the patients regarding their drug history. Let's start with Alzheimer's. So what is Alzheimer's? Alzheimer's is a disease of the brain which is different from normal aging. Okay. So what happens is that there is damage of neurons. Which neurons? The neurons which basically play a role in memory, language, and thinking. That is why the preliminary symptoms of Alzheimer's are also related to these. So Alzheimer's was basically identified by Dr. Eloy Alzheimer. He examined the brain of a woman who he has been following up for around 5 years till the time she died. After doing an autopsy, Dr. Eloy Alzheimer found tangles and plaques on the brain histology. And from there started the journey of Alzheimer's disease. Until now, it has been almost more than 100 years, and we are still struggling to find the root cause of Alzheimer's and find a proper treatment for the disease. So let's go over some statistics. So the statistics suggest that over 6.5 million Americans have Alzheimer's. 73% are 75 years of age or older, and nearly 70% of all dementias are Alzheimer's, that we have already discussed. But the most striking feature of whatever statisticians do is this projection that by 2050, the number of people of age 65 and older with Alzheimer's dementia is projected to reach 12.7 million. Now, this is something really devastating that's going to happen. And that is why a lot of research is going in this direction. And we also know that Dr. Wang, as she suggested yesterday, that she's also researching in the same area. And we must commend such people that they are going really ahead with all these kind of researches. Now, what happens in Alzheimer's is that learning a new information takes longer. When I say takes longer, sometimes it doesn't happen also. Now, what we see here is an image on this side, which is depicting the projected increase between 2020 to 2025 in the cases of Alzheimer's dementia, prevalence by state in the United States of America. I also took out data, and the projection for Washington, D.C. stands at 1.1%. So, what are the risk factors of Alzheimer's disease? The number one risk factor is advancing age. So, after 65 years, every 5 years, there is doubling of symptoms. That is, the severity of symptoms increases twofolds. And 1 in 3 people aged more than 85 years have dementia. What are the other risk factors? There's family history, there's genetics, of course, there's lack of education, there's cognitive disengagement, and if the patient has low level of socioeconomic status, has lower levels of education, he or she is more prone to getting Alzheimer's. What about African Americans? They are at a 2 times greater risk. Now, here I would want to add a point that there is also increased risk of cerebrovascular disease in case of African Americans. Now, when cerebrovascular disease occurs in cases of African Americans, it also predisposes them to developing Alzheimer's at a later stage. In case of Hispanics, it is 1.5 times. What about women? Women, 2/3 of the affected population are women. At an age 65, 1 in 6 chance is for the women and 1 in 11 for the men. There's one more risk factor which is very important, and it is traumatic brain injury. In case a patient has a history of traumatic brain injury, there is 4.5 times increased risk of developing dementia in that particular patient. So let's talk about the warning signs. What are the warning signs? There is memory loss, there's difficulty performing familiar tasks, there's problem with language, there's poor judgment, disorientation to time and place, spatial disorientation, withdrawal from the work or the things that they loved to do, there's change in mood and behavior, misplacing things, disorganization, and problems keeping track of things. And these symptoms, if these signs and symptoms are developing new, they may be a sign of dementia. So here we compare on both sides. One side there is a healthy brain, and other side there's this Alzheimer's disease brain. So we see that in case of hippocampus, which is very critical for formation of new memories, in case of Alzheimer's, that hippocampus region shrinks severely. That is why there is decreased ability of learning new information. What happens to the cortex? The cortex shrivels up, and the areas involved in thinking, planning, remembering, organizing, all are affected. That is why the symptoms develop. Stages. Now there are 3 stages: mild, moderate, and severe. What happens in the mild stages? The patient is forgetting just familiar words, losing everyday objects, trouble remembering names. And till the time the patient reaches this stage, the disease process had already started almost 5 to 10 years earlier than this. It's just that the symptoms are being reflected upon now. What happens in the moderate stage? The patient starts forgetting his personal history. There's confusion about the place and time, there is disorientation, there is change in sleep pattern, there is increased risk of wandering, and if the patient is wandering, there is risk to his safety. There's personality and behavioral changes. The patient needs assistance with bathing, toileting, and dressing. What happens in the severe stage? This is the longest stage. It requires full-time care, and the patient might be at risk of developing various kinds of infection. There's lack of awareness to the patient's surroundings. Patient is not aware at all, not oriented to time, place, person. Let's talk about the clinical hallmarks of Alzheimer's disease in terms of pathophysiology. So what happens here? So Alzheimer's disease, we discussed 2 things: beta amyloid plaques and neurofibrillary tangles. He is Dr. Aloy Alzheimer, who basically described these 2 things in that female. So what happens inside the brain? This is a particular neuron. It is a normal neuron. We have amyloid precursor protein, which is a synaptogenic protein, and it also helps in the repair of the neurons which have been withered out. Now, since it is a protein, after it is withered out, it has to undergo a process of degradation, right? Just like normal protein. So who does that? This particular degradation is done by 2 friends, gamma secretase, alpha secretase. They work in tandem. They break down APP into a much more soluble form, and this particular soluble form is removed from the body. No problem. The problem arises when this gamma secretase and alpha secretase is replaced by couple of gamma secretase and beta secretase. What is the problem here? The problem here is that there is abnormal cleavage, and whatever product is remaining is an insoluble form. It gets crumpled up in form of amyloid beta. And this amyloid beta, what it does, it deposits around the neurons, thereby forming amyloid beta plaques. Now, this amyloid beta plaques can further cause neuroinflammation, can further cause cerebral amyloid angiopathy. Now, this was about beta amyloid. Let's talk about neurofibrillary tangles. Okay. Before we talk about neurofibrillary tangles, let's talk about microtubules. What are microtubules? So microtubules are like a highway, okay, from which the cargo truck has to be transported. And for that smooth transport, they need two things. They need map and tau. So this is map and tau, map and tau. What happens in Alzheimer's is that the tau protein gets phosphorylated. And once this tau protein gets phosphorylated, it forms neurofibrillary tangles by clumping together. Here is the clumping. So neurofibrillary tangles is inside, beta amyloid is outside. Now, earlier I talked about that the beta amyloid can cause neuroinflammation, right? How does it cause neuroinflammation? It causes neuroinflammation through the following process. What happens when there is beta amyloid deposition? It also increases the glial cells. What are the glial cells? Oligodendrocytes. Oh, sorry. Just a sec. Okay, so what are the glial cells? The glial cells are astrocytes, microglia, and oligodendrocytes, right? So what happens is microglia tries to break this down by secreting cytokines. Now, while it is secreting cytokines, the astrocytes are also affected, and they change into another form of astrocytes, which further causes neuroinflammation of the neurons. Okay, so this is a kind of a vicious circle. Neuron, beta plaques, microglia is activated, secretes cytokines, astrocytes are converted into reactive astrocytes, and that in turn again affects the neuron. So this is the basic pathophysiology of what is happening in case of Alzheimer's. And since you see it is a complex process at various cellular levels, that is what makes Alzheimer's difficult to be treated. So these are the three hypotheses. We discussed amyloid and tau. Cholinergic hypothesis states it is basically acetylcholine which is important in memory and learning. So cholinergic hypothesis states that acetylcholine is in deficit. That's why the memory and learning is affected. Let's come to the diagnosis. So diagnosis per se is mostly clinical on the basis of neuropsychological testing, but now it has also been complemented with novel biomarkers, imaging, etc. So for diagnosis, we use the MMSE score and the Montreal Cognitive Assessment. Okay. So here we see the form for the mini mental status examination, but it is really difficult to differentiate other forms of dementia on an MMSE. So basically it is used for the cognitive deficits that may be encountered. Another test that we commonly use is the clock drawing test. Okay, so as you see in the figure, a normal clock looks like what is shown. This is mild cognitive impairment, the first one, and the late one is the late Alzheimer's disease. So what does this signify? It basically signifies the function of the prefrontal cortex and the spatial disorientation of the person. Okay, that is why this particular test is important. Now we come to imaging. So when we do a T1 weighted MRI, we can see the atrophy in the brain. Okay. In the first image, there is no atrophy. In the second image, mild atrophy can be appreciated. Third, it can be appreciated really well, moderate atrophy, and severe atrophy in the last image. Now, what is atrophy? Atrophy is basically widening of cerebral sulci, gyri, and the gray matter thickness is reduced. There can be enlargement of the ventricles or the subarachnoid spaces, which is clearly appreciable on the MRI images. Then there are brain scans. Brain scans also help identify Alzheimer's. Alzheimer's in a brain scan in a normal patient will look like what we have an image on the left side, and you can clearly compare it with an image on the right side in an Alzheimer's patient. So basically, the yellow areas are the regions of brain activity, which are substantially reduced in the image in the Alzheimer's patient. Now, another image that has come up, imaging process that has come up is amyloid PET. Now, amyloid PET is basically a PET scan, okay, but it has been implicated in a new way now in the form of tau PET. Now, what is tau PET? So, through various autopsies, we have accumulated results, and we have seen that basically tau accumulation follows a temporal stereotypical pattern known as Braak staging. And we have graded the staging of patients in case of Alzheimer's from stage 1 to 6 according to howsoever the tau accumulation has occurred. Okay, so this image particularly shows you how Alzheimer disease related clinical deterioration is occurring throughout stage 1 to 6. Now, this is one novel biomarker technique that is going to come up in a substantial way, and that has to be detected through the blood. And this is still under research, but once it comes in a big way, this would be a game changer. So let's now come to our second part of this presentation, which is coping and understanding. So what is coping while caring? So coping while caring is that once you have a patient with Alzheimer's, how do you try to increase his daily living in a better way? Okay, so the first point, set realistic and attainable goals. What do we mean here? So we mean that you're asking a patient to do certain tasks, maybe make a figure of block of 10 blocks, keeping 10 blocks one over the another. Now, the patient is able to, you tell the patient that you have to make 10 blocks. Okay. But according to the cognitive assessment of the patient, maybe he's not able to. So rather than keeping a goal of 10 blocks, you should rather keep a goal of maybe 5 blocks, 6 blocks. So once the patient attains that, that will be small victories for the patient as well as you. And the patient will develop confidence for his next task. Anticipate misinterpretation. What do we mean here? Here we mean that, whenever you are trying to tell the patient anything, the patient might not understand in the way or form you're trying to tell the patient. So what can we do for that? We can use simpler words. We can use clearer words. We can use clearer instructions. Okay. And the third thing that is important is repeating it. Don't mind repeating it. Because if in case there is misinterpretation, it will bring frustration to the patient, and it will also bring frustration to the caregiver. Third, remember that all behavior has a purpose. If the patient has anger outbursts, that is purposeful, that is not purposeless. It is because the patient is trying to draw your attention towards something that he's not liking. So you have to pay attention to any kind of behavior like this. You don't have to retaliate or maybe shout at the patient or have anger outburst in your own self. Enjoy the good times. That means that while you're outside with the patient in an outdoor setting, you should always try and include certain activities so as to make the whole activity more enjoyable. Reminisce about the past. This is one thing that I really want to highlight. While you reminisce about the past, you will have to not ask the patient that, do you remember this? Because he might develop a sense of insecurity that, what if I don't What if I don't remember? What if I am not able to answer it? Rather, tell the patient that there was this time you and me were doing this certain things. Give your own examples. Okay. Now, another thing which is important, that we do certain routine things at the same time every day: dressing, bathing, eating. Okay, planning activities and trying to do the same activities same day, even if it involves exercise or whatever. The clothing should be loose, easy to wear, and everything. Okay, you have to, whenever you're dressing or bathing, try to let the patient do as much as possible. You don't have to assist the patient in everything, whatever the patient is doing. So here, I guess, if you try to limit the patient will limit himself. Okay. Again, while we are talking about serving meals, we have to serve the meals in a consistent, familiar place and give the person enough time to eat. Okay. So when we evaluate the patient's need for supervision or behavior, we have to review some things. Is your patient able to handle emergencies if you are leaving the patient unsupervised? Is the patient able to use all the electrical appliances safely? Will the patient be able to answer the phone, or can the patient be left in the home alone? And what is the tendency of the patient to wander? What are the supervision strategies that may be included? There can be simple reminder phone calls, there can be alarms and doors, there can be personal supervision. So this is what I said. Don't say, do you remember? Try to remember. Did you forget? How could you not know that? These are negative statements, and they decrease the confidence of the patient. Okay. Rather, use repetition. Rather, listen attentively. Rather, use distraction when there is something else, when the patient is talking about something else. Okay. Also, there is one more thing. There's fibbing, therapeutic fibbing, that you basically lie to the patient in a way just to control his anger. And it is done in some cases. Therapeutic fibbing has been proved to work in some cases. It doesn't have to be made a daily activity, but it can be used. Now we come to another module, that is caregiver support. Now, whosoever cares for the patient, uh, Alzheimer's disease or dementia per se, can have a varied experience. Okay, it is full of grief, and it is very difficult to cope up with. The person with dementia will change maybe every day over weeks, and it's upsetting. So it is not only very challenging, but also sometimes it makes you learn through the whole process. So in the early stages, accept it. You know, here the Kubler-Ross grief cycle works very well. You are in the denial earlier, then you go through anger, depression, you go through all phases. Okay. So accept the diagnosis. How can you do it? So start helping the patient. If the patient is mildly cognitively impaired, you can talk to the patient and make sure that you're going through this process together. You can help the patient with short-term memory loss by rather not helping it helping him totally, but rather helping him keep notes. Okay. Prepare for the road ahead, as in, now dementia has to progress. It cannot just be there where it is. It has to progress. So you have to decide how you're going to go about it in the long term, financially, emotionally, in the state of shifting to a setup where the patient can be more comfortable or whatever. Okay. Now, in the middle stages, just accept that you cannot do this alone. Okay. It is okay to ask for help, and it is okay to say yes if somebody is offering help. In the late stages, it is actually very difficult. The patient is totally dependent and requires a 24-hour care. And if you're a caregiver, there will be new challenges. There can be end of life decisions as well to be made. So during this whole process, the caregiver burnout is an entity that actually occurs. And it is associated with anxiety, depression, irritability, difficulty sleeping. The patient neglects him, the patient is affected, as well as the caregiver starts neglecting himself or herself. So the caregiver starts neglecting any leisure activities, maybe gets addicted or overconsumption of any kind of psychotropic substances or alcohol, right? So what we need to do in these cases? In these cases, we can totally look for support groups for caregivers, and it is very natural to feel burnt out, but we'll have to, as a caregiver, you should be assuring yourself that you are here for something that you're offering to the patient, but you yourself are a human and you deserve the time off. So go take a time off, have a leisure activity, do what you like. Uh, that's totally fine. That's totally fine. Okay. So Alzheimer's disease is a lonely journey, and it is very important for the caregiver or for the family members or for the society as a whole to support the patient in this journey. Uh, and I last year I had written a poem on the day of Alzheimer's Day, September 21, which is about a patient who is talking, and he says that don't ask me your name, don't tell me I'm not being the same, don't ask me to understand or to remember. Just sit beside me, hold me if the fear makes me shiver. Don't lose patience with me or ask me to speak. Accept it rather, that the tangles have made my brain weak. And this won't change no matter how hard we try. Just hold my hand while I cry. Sometimes I can't remember as I stand in front of the mirror if I must comb my hair. Sometimes on the stairs I forget, was I going up or down somewhere? I know it must be difficult for you to watch me become less of the person you knew. For the memories are gone, and as the length of our communications shorten, I only ask, don't let the people who forget be forgotten. And with this, I end my presentation. Thank you so much.